like a lumbar laminectomy, those were the easiest by far. Those patients, so they originally, what their issues were before their surgery would have been horrible sciatic pain down one or both of their legs to where excruciating pain. And if they had a pinched nerve over by their lumbar spine area, and they did a lumbar laminectomy, which is where they strip off part of the bone and take off some of the pressure off that nerve. They all of a sudden, after that surgery, they were awesome. All they had was a little bit of pain from where they were working, but no longer pain in their legs, that sharp pain down their legs. Those were awesome. We would also have surgeries with cervical area back behind their neck, like a fusion. Those were harder. They would have a brace, and actually some of the lumbar laminectomies too, if they had a fusion, they would have a brace, and those were more difficult too to recover from. But these surgical patients, they were for the most part, very happy with the results, and those were good patients. Now, I worked nights doing this surgery, and to be honest with you, on average, I would have 6 patients a night. And these were high acuity patients for the most part. Because I wouldn't just have the surgical patients. I would have patients that may have been in isolation. Maybe they had meningitis, and I would be in their room, gowned up, masked up, and be in there for an hour at least, giving them all their medications, and some, a lot of times they were not awake, so sometimes they had a G tube, and so they're going, so having to put them in their G tube, or and then IV medication. A lot of times they were not awake, so in the nighttime, a lot of times, the family members aren't there, so they're not there to help. But I learned so much. So there's that, and then those nights went by fast. There weren't ever, if you've ever have any fears of like having to start an IV, they always had an IV. I think I was there for 9 months, a little over 9 months, and I think I started one IV because they always had one, and they weren't always there that long. But that's not something that you usually have to worry about. And then where I worked, yes, everybody had labs in the morning. Where I worked, they had phlebotomists that would come and draw the blood, even if they had a PICC line or a central line, like a port. But it was easy as far as that. Yes, sometimes we would have other patients, such as GI patients. I am not a GI person, not my favorite thing. I don't like poop. And sometimes I had patients that I had a trach, and that was to be honest with you, the thing that bothered me most as far as bodily fluids, it would have been sputum. In nursing school, it was disgusting, just sputum. It was my thing. That's the one thing that could make me gag. But working in this unit, it made it so that I was no longer, it kind of desensitized me for that, because I did have a couple of patients that had a trach, even though it was a med-surg unit. This unit didn't have all private rooms. It probably still doesn't to this day, but there were some. And having to like suction a trach and stuff. Yeah, after a while, you just kind of get used to it. Unfortunately, I don't want to say unfortunately. Fortunately, you just get used to it. Um, a lot of times at nighttime, you're not having to do a bath, but sometimes you are. Sometimes you do, and you just grab your tech. Um, I'm trying to think of some of the other things I would have done. Oh, like lots of stroke patients. Even at nighttime, they're sometimes going for an MRI. You're having to do I forgot what it was now. And is it the NIH scale? I think it's the NIH scale. I'm sorry, I forget what it's called. But this basically I'm probably giving you the wrong information right now, and I apologize. But to if the patient had a stroke, or if you're trying to see if the patient had a stroke, and by the time they come to this unit, you know if they've had a massive stroke or a TIA, which is transient ischemic attack, you know. But and then so there's scales that you have to do. There's also some screening that you have to do, like a swallow screen when you admit a patient. I just really liked it. I learned so much when I was on this unit. It was kind of nice. It was very nice, actually, for my first nursing job. Even though when I went to nursing school, what I wanted to do was OB. I always wanted to do OB. I've always loved pregnancy. I always loved labor and delivery. Always loved it. But it is nice to start learning other areas of medical field before you go into labor and delivery. I think there's a lot of times now that you don't have to do that. I didn't have that option. I had to go into something else besides labor and delivery, even though that was only 15 years ago. But you know, still even to this day, I love nursing. And each of these videos that I'm going to be doing, I'm gonna kind of describe each of the specialties that I've worked in. So this was neuro. I liked it. I really liked the people that I worked with. I did work nights. Nights would never be my first choice. To give you my age, I am 46 years old. I worked all day long, and it's almost 6 o'clock at night, so I apologize for the way I look. I don't really care. For you right now, I hate to say that, but that's just the way it is. But I'm not a beauty blogger, so vlogger, I should say, not blogger. So I don't really care how I look right now. I just want to kind of describe some of the things that I did as a neurotrauma nurse. Have I done any kind of codes? Yes. On that unit, I did. I had one, and it wasn't a neuro patient. Well, it was a neuro patient because they put him on there because this was a very high, this was a diabetic patient that had some just some changes in his behavior, so they put him on our unit. We did have to transfer him to the ICU, and we did have the code team come at one time because he was extremely hypoglycemic, and I think it was right when I got on shift, and I'm not sure exactly what the day shift nurse did. And this was 15 years ago, so I'm trying to remember. And then there was another patient that I helped with a code. Because sometimes we would get patients on our floor that wasn't neuro but needed continuous telemetry, cardiac telemetry screening. We had to watch their cardiac strip all the time. And this patient, and it wasn't my patient, but I did help with another code on this floor because of that. But yeah, so it kind of depends on what kind of hospital you're working in and what kind of acuity the unit is, as far as when you're working in a neurotrauma unit. But I liked it. Honestly, I feel like it was probably the best floor I could have started out as a as a new nurse, besides working in the labor and delivery OB unit, because I mean that's where I ended up with, and that's what my passion is. But I learned so much during this time. Let me know if you what kind of questions you have as far as working in neuro. Some of the surgeries. I remember so much still, and what it's like working at nighttime, especially as a 32-year-old. I had two little kids, married, and how I dealt with that. See you later.